Hi, folks. Hopefully some more folks will join us as we go, but it is summer, so people are on vacations. I'm Janice Karen. I'm the co-chair of the WEDI Health Equity Work Group, and I will also be the speaker today. I'll be talking about disability access in healthcare from a couple of different perspectives. Does anyone have anything else they'd like to discuss or bring up to the group before I start my presentation? If not, then I will go ahead and start sharing my screen and we'll get started. Feel free to interrupt me at any time, and I've also set aside a little bit of time for questions at the end, but feel free to just interrupt and ask me stuff as we go along if you prefer. Can everyone see my screen?
Yeah, looks great.
All
We
right.
can, yep.
Excellent. Oh, it would help if, there we go. All right, so I'm Janice Karen, and I will have a slide with a little bit more info about me in a moment. I work for the Massachusetts Health Data Consortium, also known as MHDC. We are a health data nonprofit that has been around since 1978. We work with all aspects of the healthcare industry. Like WEDI, we have payers, providers, vendors, associations. We convene the health data community in Massachusetts and New England. We are locally focused, but nationally, we put our feelers out. We spend a lot of time looking at how to modernize health data and data exchange and navigating federal and state regulations, and also look at how to empower the individual to get their health data and health equity and a lot of other areas. So I'm not going to toot my own horn or read my data, but I'll leave this slide up for a moment if people would like to know a little bit more about me. Well, the one thing I will say is that I lead my day job. Many of you know me through WEDI events, but my day job is our Data Governance Collaborative, which I will tell you a little bit more about on the next slide. So the Data Governance Collaborative is a one-stop interoperability resource, and we meet once a week for 90 minutes to discuss, design, and implement data sharing and interoperability among payers and providers, patients and members, and other interested parties. We are traditionally focused on payers and providers and helping them work together. We focused on 3 areas: collaboration, which includes development of understanding of what things mean, as well as actual spec development. We have a quality measure specification, for example. That was our first long project. Education, helping members understand regulatory obligations, data and data exchange standards. As part of both of those efforts, we comment on a lot of regulations. And then also our third arm is innovation, identifying and sometimes developing projects and services that are needed to make the modern healthcare data practices move forward. And so that's sort of what DGC is and what I do on a day-to-day basis. So as I mentioned, we do a lot of regulatory work. We review and comment on RFIs, guidance, proposed rules, other documents, not just all over HHS, but also other areas such as the FTC, CISA, the OMB. We've commented on things from the NIH and from congressional offices before. So really anything that we find that impinges on the areas that we focus on. Some of the areas that we focus on include data standards and quality, interoperability, patient access, patient experience. We do a lot of work around privacy and security and health equity, price transparency, including the No Surprises Act, but also more. Quality measures is traditionally the first area that we focused on, AI and more. You can find all of the comments at the link that's on the slide. These slides will be available later for anyone who'd like it, so you'll be able to just follow the link directly. So why am I here talking to you about disability access? So our DGC produced 2 comments on this area in 2023. And these links go directly to those comments when you have slides. The first one is AHRQ's key question on healthcare delivery of preventive services for people with disabilities. And we also commented on the now recently finalized HHS OCR discrimination on the basis of disability in health and human service programs proposed rule. So where did the content for these comments come from? We held two what we call deep dives, which are public discussions, typically 2 hours long, on a specific topic, either a specific type of data or a specific type of care. For instance, we've held them on physical therapy and eye care, but also on immunizations, family history data, etc. So we've held 2 of them on SDOH, and one of them in particular talked a lot about some of the material that fed into those comments and will feed into this presentation. Excuse me. We also have ongoing periodic discussions in our weekly DGC working group meetings that impinge on these topics. And we also had specific discussions where we looked at the AHRQ key question and also the OCR proposed rule. And so all of those conversations and materials were fodder for the comments, and those comments are the basis of this talk. So today we're going to focus on 3 areas that were initially covered in the AHRQ key questions comment, and we duplicated them in the OCR comment. We actually appended our entire AHRQ comment to the OCR comment because we felt like it was relevant and stuff that we wanted OCR to know about, and it wasn't necessarily stuff that they were focusing on in the proposed rule, but we felt it was important. So there were sort of 3 areas that were covered. One was systemic issues and provider policies that affect equitable healthcare access for disabled individuals. The second one was data collection of healthcare accessibility and accommodation needs. And the third one was data sharing and interoperability of accessibility related data. There's lots of other areas that are important and that we could discuss. There's a lot of questions around the definition of disability that are important, just treating disability as an SDOH factor that are important, but these were the 3 that we focused on in the comments and that we'll talk about primarily today. I'm just going to pause very briefly. Are there any questions about the framing or what we're going to talk about? All right. So why are these the things that we're talking about? So why systemic and policy barriers to care? We believe in eating your own dog food. That's a tech phrase that means that if you're going to talk about health equity being important, then you should make sure that the activities that you do that are under your control take that into account and prioritize health equity. And these are items that are mostly or entirely under the control of provider organizations. There are competing priorities, so I'm not saying that all of these are easy things to address, but they are things that are being set by the organizations themselves typically, and therefore they're areas that are more likely to be changeable by the organization than some of the other things which are wider issues. Data collection of accessibility and accommodation needs, because right now disabled individuals have to show up and hope that their medical appointment is accessible and that they can accommodate their disability, and that's just a bad look. People should know that the data that's needed to support them at their appointments is there and has been taken into account by the people who are treating them. And similarly, for the data sharing and interoperability, once a disabled individual has provided information about their accommodations, assuming that those are things that they generally need, they shouldn't have to repeat it every time. It should be available. And also, to make it easier on the people who are trying to accommodate the patients, they should know about the needs ahead of time and not have to find out at the appointment when it may be too late to do anything about them. So what are we going to talk about on systemic and policy issues? Sort of 3 categories of things: physical facility issues, actual policies, and then what I'm calling workflow barriers. And you can see that there are a couple of items under each. These are not at all inclusive. There are other things that may have big effects that you should look at your organizations and evaluate, but these are specific ones that came up in our discussions and that people we know about have had issues with. So motorized wheelchairs. So assuming motorized wheelchairs are the default is a bit of a problem. In fairness, a lot of the actual physical accessibility laws do this too. So it's not entirely the fault of the individual organizations, but healthcare organizations should be held to a higher standard because they have a lot of patients who are physically disabled who are not in motorized wheelchairs. So one of the biggest issues that comes up is that patients who are not in a motorized wheelchair but have some type of mobility issue often have a tighter turn radius. So for instance, if you're in a manual wheelchair or a walker using a walker, you can't turn as quickly or with as you need more space to turn than someone most than an average person or someone in a motorized wheelchair. And some of the issues that crop up, I'm not going to read all of these in excruciating detail, are being able to actually access automatic door open buttons safely. The biggest one, the one that's probably the most changeable and most adjustable from a healthcare perspective, are the snaking lines that have the rope lines that turn left and right till you get to the front. Those are often not accessible to disabled patients. And there can be issues with turning into checkout areas or having checkout areas blocked. And that actually ties sort of the second and third together: chairs, equipment, unused wheelchairs, etc., blocking doorways and other places. Again, the checkout area is one that's often blocked. Here, the chairs that are there for patients to sit in who don't have disabilities can often keep someone with a mobility disability from getting very close to the actual desk. So those are some of the issues there. Seating. One of the things that isn't very widely addressed, not very widely discussed, is that there are seating limitations for some patients. They have to sit with a leg to the side, or they can't sit in certain types of chairs. And often the simpler chairs are better for many patients. And a lot of offices have moved to nicer chairs to make it more pleasant for patients in the waiting rooms. And so sometimes there can be a little bit of a mismatch with chairs. And this is not just in the waiting area. This could be in actual exam areas too. Or there could be one or two chairs in an office that would accommodate the patient, but they have to move around, and that's something that isn't widely done. That kind of stuff is that impinges a little bit on the policy and workflow side too, but this can be a big issue for patients. So I'm going to stop here again and ask if anyone has any questions or anything they'd like to bring up on these topics. All right. So let's go ahead and look at some of the policy things. So we talked about physical issues with motorized wheelchairs, but there can also be policies around the policies that exist around accommodating disabled patients are often solely designed around patients with wheelchairs. And in particular, there may be exam spaces that are designed for disabled patients, or not maybe solely for disabled patients, but to better accommodate them. And they get prioritized for patients with wheelchairs, even if sometimes the patient with the wheelchair doesn't need them for that visit. And there may be other patients who aren't in wheelchairs who do need them but can't access them. And this can get exacerbated by having a reservation system where clinics are so afraid that the room is going to be in use when a wheelchair patient arrives, that they reserve it for hours ahead of time, or sometimes for half a day, even, so that it's available for the entire time that one patient needs it. And that also limits the availability for other patients. And again, going back to that physical barrier, it is often harder for patients who are not in wheelchairs to get staff to move things for them that are blocking their pathways or preventing them from going someplace they need to go. And it's often, again, more difficult for some of those patients to navigate around them, but there's sort of an ingrained policy of, we need to accommodate this for people in wheelchairs, and those are the people that we need to make adjustments for. That is not always helpful for patients with other needs. So another big issue is around arrival times, and this is an issue for every patient. This came up, for instance, in completely non-disability related discussions in our SDOH discussions, but it really is a big issue. It can be a particular issue for patients with disabilities who maybe are less likely to be driving themselves. may be more likely to rely on public transportation or paratransit services. Many provider policies say that if you're more than 10 or 15 minutes late for an appointment, you have to reschedule. There are even some tests that are tightly scheduled where you can't be late at all. And disabled patients can run into a lot of extra barriers where no matter how much extra time they leave, they still don't get there on time. Often there's one accessible subway car in a train of subway cars, and the ramp might be broken, the doors might be broken, or only one door opens and you need both doors to open to get on if you're disabled. The only wheelchair securement area of a bus may already be in use, so you may have to wait 45 minutes, an hour, or even an hour and a half for the next bus sometimes. And so those are all issues that don't affect other patients that might affect a disabled patient. It might take them longer to transfer, so the transfer times that are allowed for transferring from like a subway to a bus or between two buses are deemed sufficient for most people, but they're not long enough for the disabled patients, so that extends their travel time. And if you're using paratransit, those routes can be very circuitous, and they could take you 2 hours to go someplace that's a 10-minute drive away. So there's lots of issues around that there are coping mechanisms and ways to limit the amount that they affect things, but there's really just going to be a larger percentage of the time where patients who are disabled who rely on these methods for transportation are going to be late, even if they leave 3 hours before the appointment. So another thing is audio-only telehealth. A lot of clinics have started deprioritizing audio or even stopping support for audio-only telehealth entirely since the official end of the public health emergency about a year ago. But this is important for disabled patients. And just a few examples. Patients with mobility issues in their hands may find operating the software for video visits difficult. Patients with visual impairments may find that the video software doesn't work with their necessary computer settings or can't be seen well enough to use on mobile devices. And patients with auditory impairments may have assistive captioning technology set up to use with their phone service and find it easier to use that than an application that isn't directly designed for the hearing impaired and that may be inadequate. So any questions on any of this?
Janice, I have
All
a
right, so let's
question
look
on
at,
that. If you
sure.
would just go back up,
Yep.
I'm curious as to your insights into why these organizations are moving away from audio only. It seems like it's more cost effective. It seems like it could be useful for both the provider and the patient. But as you point out, many are switching to video only. Do you have any insights into sort of what's pushing them to this?
Yeah, I think that there are a couple of things that are done. I think one thing is that there's still some reimbursement disparities in some cases. And although some of them are not, there are states that have put in rules that disallow that, and some of the federal exemptions are still in place. Those have been going away. There's a thought, even in general, for telehealth generally, there's still a lot of people who think it's something we did during the pandemic or something we did during the height of the pandemic, and therefore something that we can phase out now that the worst of the pandemic is over. And they don't think about it as something that should be a normal part of our ongoing healthcare. And just there's a sense from some people that they're missing information about the patient if they're not seeing. Now, there are generally things that clinicians need to look at, that they would either need to have a video visit or an on-site visit to appropriately treat. And we're not talking about those things. Obviously, if you wanted someone to look at a rash, they need to be able to see the rash. But there are plenty of things that are really consultations, or where there really is no reason it couldn't be done audio only. And I think there's some of just we've never done it that way, that seeping back in. Or also it can be really hard to transfer. So if a clinician has appointments where they don't have a block of this type of appointment together, going back and forth from on-site to video to audio only, I've heard from some people, is a pain. And so there can just be let's take one of them out of the equation and only have to deal with 2 of them. So those are some thoughts. And does anyone in the audience have any other thoughts on that? All right. Does that help, Denny?
No, that was very helpful. I didn't think of several of those. I appreciate it.
All right. So I'm going to move on then if no one has anything else. So let's talk about some of the workflow barriers. And the biggest one is automation. Automation is great. I am all for automation. And the problem with automation is that it's designed for the 80%. And it works brilliantly for people who are in that 80%. But if you're in the outlier, if you're at the edges of the bell curve, if you're in the 20% of people, you know, again, that's sort of an 80-20. It doesn't mean it's really 20%. But if you're in that group of people where you need something special, you need something different, you can't follow something automatically, then if automation is a problem for you. And one of the biggest areas for automation right now is check-ins. And this really poses a lot of problems for many disabled patients. And again, these are just some examples, but patients who are blind or visually impaired may not be able to follow signs telling them what to do or see UI elements on a tablet being used to check in. Patients with hand mobility issues may not be able to fill out information on the tablets directly. Some of the affixed tablets may not be physically accessible to patients with mobility disabilities. If someone's in a wheelchair, a tablet may be too high for them to access. And there are all kinds of other issues that can crop up. In addition, there are patients who might need additional assistance. They might need to remind the clinicians of something. For instance, if you have to take a medication regime in order to do a certain procedure and there's a time frame in which it's effective, you need to be able to remind the staff that you have to be seen within a certain time window or you can't be seen at all. Or you need to remind them if there's no chair that's visible that you can sit in, you need to be able to ask someone for the chair that you need. And none of that happens when everything's automated. So patient portals are another big issue. Patient portals are great, but there's this thought out there that digital interfaces are automatically accessible, and they're not. And in particular, in the healthcare world, patient portals can be really problematic, especially for folks who are visually impaired. And one issue that happens is that there's sort of an assumption of a minimum screen resolution, and low vision patients often cannot meet that resolution and still function. And so when you're using a patient portal and it doesn't like your screen resolution, lots of things can happen. It can fail to open entirely. It can display with the UI elements superimposed on each other. You can have critical UI elements off screen so that you can't actually you can't complete the login screen because you can't submit because the submit button is off screen and you can't submit using enter. And so you have no choice but to quit. So sometimes sometimes a patient may not be able to create an account. Sometimes they can't log in. Sometimes they can log in, but nothing works. So I'll also note that this can be problematic for third-party apps as well and Fire-enabled applications, because many of those apps use the patient portal as part of their authentication process. So this is not specific to patient portals, and these are not the only things that can be problematic, but there are issues with these types of things. Now, the recently finalized OCR rule says that all of these things must be accessible. So I don't know, hopefully there'll be some improvements based on that, but currently at the current time, this is a problem. Paperwork is another big issue. Some patients are unable to complete paperwork without help for a variety of reasons. Visual impairments, mobility issues with their hands, other reasons. There could be developmental disabilities or lots of other reasons. And in the past, patients with these problems were often assisted in these activities by front desk staff. But over the last 15 or 20 years, that has gone away. And there hasn't really been a real replacement for that. So at the current time, the medical staff often uses appointment time to gather this information. This is really problematic and a major equity issue. There's a couple of ways this is problematic. It can delay care if they actually get the information they need before they do care. You might have to go through 2, 3, 4 appointments before you even have your first real appointment, where all they're doing in those first appointments is gathering medical history or getting data that would have been on your form. And or they can start the care without the proper intake, which is problematic too, because they could choose less than ideal or sometimes even problematic treatments that might have been contraindicated by something that they haven't yet collected. It also forces patients to pay for the intake process, and because they get classified as an encounter. Whereas other patients who are not able to just fill out the paperwork, they're not paying for that. That's something that they do, but they're not paying anyone money as part of that process. They're paying for an actual consultation or visit or procedure or whatever. Now, some of this can be helped by making paperwork available ahead of time, but not everyone has someone who can help them with it. Some of it can be put in, some people put this in the patient portal, but we just talked about portal issues. We have a recommendation which will which we'll bring up at the end, but our data governance collaborative felt pretty strongly that there should be a disability advocate, the same way that you have a translator that can be put on call for someone who doesn't speak English well. There should be someone who can help someone who's disabled through this process. And one of the big areas that they could help with is this paperwork. And we'll talk about that a little bit more at the end of the presentation. So any questions about any of these topics? All right, so data collection. It's really important and that there be some work on developing standard mechanisms and locations for storing general accommodations needs. And this preferably should be attached to the patient record, so it's available whenever the patient is seen, whenever their data is accessed. Again, as I mentioned earlier, for many disabled patients, having to go over the same accommodation needs repeatedly is a major issue, especially if they apply all of the time. So it's not changing in any way, shape, or form, dependent on the context. There should be some mechanism for capturing this once and sharing it with consent. The consent part's important, to all of the relevant parties in the healthcare system. And it should be linked and referenced and available within encounter data, procedures, other resources that are relevant to treatment, so that it can be acted on in the right places by the right people at the right time. So that's kind of the push for, this is why this data is important. So what data? That falls into kind of two groups of data. There are basic accommodations that are required all of the time. And then there may be some specific accommodations for a particular encounter, test, procedure, other activity that's happening at a particular visit. And both of those are important. So for the basic accommodations, these are just some examples. This is not by any stretch of the imagination all-inclusive. But there are patients who may need help reading or writing text. They might need help with forms or instructions, signs, posters referenced by clinicians, all kinds of, this comes up in so many different ways. There may be patients who need adjustments to processes because of their tolerance for bright lights or changing lighting conditions or blinking lights. There may be patients where if you suddenly, if you're in a darkened room, let's say you're having an eye exam and the room is dark and you suddenly turn the lights on, you may blow them out so they can't do the rest of the exam. You need to, for those patients, you may need to warn them, let them close their eyes and let them readjust to the lighting slowly until they're able to function in the brighter lighting. That's just one example. You know, again, there are patients who may not be able to hear things clearly or may have other auditory input issues, and they won't necessarily know if you're calling their name from a corner of the waiting room to have them come back, or they may not be able to follow verbal instructions as well as other patients, or understand clinician explanations, or any number of other things. Again, patients who have limitations on walking, standing, sitting, body position, stair use, how long they can do any of these things, how often they have to change some of these things. There may be patients who, again, we already talked about chairs. They may need certain types of beds. There might be certain types of equipment. They might need a particular type of wheelchair if they're being transported. All of that should be noted somewhere. And again, we mentioned this in an example earlier, but there can be some time-sensitive requirements. And one of the biggest ones there is having a medication regime that's needed to help facilitate something that's happening at an appointment. And those typically would have a very strict timing and wear off over time. So you might have a window of 30 minutes where you can actually be productively do something that takes 10 minutes long to do. So you need to be called back and served in that 10-minute time. And you may have to start that process an hour beforehand. So when you arrive, you're already in the middle of that process. You have to let them know this is the window that I can have this done. Having them know ahead of time that you'll be doing that makes that process a lot easier. Any questions about any of this, or anyone want to toss out some other stuff? And as with all of the previous slides, we go into a lot more detail on many of these things in the comments that we sent, particularly the one to AHRQ. So if you're interested in any of this, I definitely recommend taking a look there. All right, so here's an example. So each of those things there's lots of different ways that they can affect things. So a patient with limitations around body position or changing position, these are just some of the things that might cause issues. And they may have something that's entirely different, and none of these are problems. But so a patient with those issues might need to return to a neutral position to move rather than shifting in place. If you're getting some type of radiology exam, it's really common to be told to lie down and then adjust an inch over to the left. There are patients who can't do that. They have to stand up. You tell them where to plop down initially, and then they can, with difficulty, maybe get their legs up, but they can't scoot around. And they often need extra time for some of those exams, because the repositioning process is going to take a lot longer because they have to start over from scratch with every repositioning. There are patients who may need help getting up after they've prone or seated, and so that may require an extra person or some extra time. Again, sort of going to that same example with the radiology, I've been in radiology exams where instead of telling me to move an inch to the left, the tech has tugged me on the sheet an inch to the left to move me to where they want me. If you did that to some patients, they would be screaming in pain, or perhaps you might injure them. And so you need to be able to know, I don't condone them doing that for any patient. I don't think they should do that without talking to the patient, but it is something that happens now, and so therefore it's something that people where that's going to be a problem for need to address. Another big one is the movement of adjustable beds while on use. For instance, if you go to the dentist, you typically sit down in you're basically with your body at 90 degrees upright, and they lower you. Well, some patients may need the bed to be lowered and then lower themselves onto the bed because they can't tolerate being seated, leaning back, having the bed move while they're on it. And again, there might be some need to have them take a medication regime in order to even get into the positions that you want. So these are all things that might happen. And there may be many other things. These are just things that we thought of. And that's just for one issue with limitations around body position. So each of those other issues may have a similar long list of things that could cause problems, and they all need to be addressed. Any questions there? All right. So one-time accommodations. So these are things where the patient doesn't necessarily know ahead of time that there are going to be issues beyond what they have at any other visit. But there may be something about a particular test or procedure or exam that they're getting that that needs some adjustment in order for them to be able to do the test. Or maybe it needs some adjustment in the way that it's scored or evaluated. And so these typically take some type of conversation with a tech or a doctor or someone who's really familiar with the exam that's happening to figure out what's needed and record them ahead of time. It may be something requires extra time. There may need to be some changes to the layout or equipment used. For instance, they may need to acquire a chair someone can sit in, or they may need to not have someone step up one step to get to a platform, but figure out how to put a small ramp on that, or things like that. They may need to modify some of the medications the patient takes and start one of those regimes that the person needs to have better mobility or to control their pain better, that they don't take all of the time. They may need to modify some of the materials that are used in an exam. They may need to come up with large print versions of paper portions or give verbal instead of written instructions or vice versa. And there may be some need to modify the interpretation. If there are tests where the time that it takes someone to complete something is considered an essential part of how the test was graded, those may need to be modified to account for the disability and the mobility or other functional abilities of the disabled patient. Any questions there?
Janice, I
right.
have a question, kind of, or maybe sort of an observation, and I'm interested in what other folks on the call think, but I'm sobered by how many touch points there are for the disabled in healthcare organizations in this context, but just in life in general, how difficult it is to understand comprehensively how all of those, how those disabilities can be accommodated and supported. And for healthcare organizations to not have this firmly in hand strikes me as at best a little ironic, and at worst somewhat, really unfortunate. But you mentioned earlier the idea of having a designated disability equity person who would act in the same capacity as like a translator would for people who have specific needs. But it sounds to me like there's also a need at the senior management level to accommodate and embed in the organization, these accommodations to make sure that they're everywhere. And this sounds like an enormous but essential undertaking. Have you seen organizations that have been particularly attentive to this, or are organizing themselves in a way to increase their ability to be successful at these kinds of changes? Or do you see everyone basically operating from sort of the same level of, catch as catch can?
Yeah, there are some differences. And I apologize to everyone, but I'm gonna use some Boston examples. I would say no one gets a really spectacular passing grade from what I can tell, but there are some organizations that do better than others. And for instance, Mass General Brigham actually has someone in their patient advocacy office who is specifically there to help folks with disabilities. And so that if you know that that office exists and you know that that person exists, as a patient, they don't exactly advertise it. You can sometimes get assistance with things that happen, but often it's after something goes wrong, they can help you fix it for the next time. And that's something that's in place. Other organizations don't necessarily have that, or maybe have that on paper. I would say in general, and I think this is part of the automation discussion, the ability for any patient to access like the patient services type things, which is sort of where this falls, has decreased over time rather than increased. And I would say that there is a need, and I think this is something that should be part of, there are all these new health equity officers, DEI offices, and people who are looking at different aspects of health equity. And this very much should be more of the conversation than it should be. I mean, I would point out that a lot of our comment to the OCR was, you're making an assumption, like OCR made an assumption in their proposed rule that there was already physical accessibility in spaces. And that's just not true. For instance, I had a dentist, there's a dentist office near where I live, where I went to for a while, where when you opened up the door to the office building, you either had to go down half a flight of stairs or up half a flight of stairs. And there was no other way into that building. And that happens all the time here because things get grandfathered into rules. It's only new construction is required to be fully accessible. The definition, people may have double doors that meet accessibility, but they keep one of them locked down. So someone who actually needs it can't get through without assistance, or needs someone to open the other door that's locked for them. Stuff like that happens all the time. So there absolutely does need to be a more systemic approach. And I think part of when we talked about I don't remember how many of the conversations you were at, Denny, but when we talked about this person helping navigate, I think part of the thought was this would be a cadre of experts that the organization as a whole could lean on to look at this more systemically. And once they had those resources in place, that they would want to take up, there would be the ability for them to help advocate for more systemic changes, as well as the things that they're encountering on a case by case basis. Maybe that's a little bit naive because I'm sure they're going to be under resourced and have too much to do. But I think that was some of the thinking that we had. I don't know if anyone else would like to comment from other perspectives. All right. And any follow-ups on that, Denny?
No, I think it's, when we talk about health equity, we often, we have a sort of a first association with what that is based on our own experiences with people we've had, we've worked with or know in our families, among our friends. But, in some respects, disability is kind of a silent inequity. It's, some people are disabled in ways that are not immediately apparent. And this requires, at least from my perspective, a pretty inside out active approach on the part of healthcare organizations, especially providers, to really go over their organizations with a fine tooth comb. And it seems to me that this isn't something that you have to do it 100% all the time. It seems like there's a level of competency in disability access that you need to achieve and manage. It's formidable, but it's there. And then you can improve that gradually over time. You can make adjustments. But right now it seems to be, sort of a catch a disability accommodation as catch as catch can. If you find something, patch something there to fix it. But there's a lack of that, as you described, that systemic view of, what does it look like across the enterprise and how do we fix it?
Well, even the fact that there were those two regulatory things, that one RFI and that proposed rule last year, to me was a really good sign, because that meant that someone on the policy side was at least starting to think about it as an equity issue. And so I do think that we are taking baby steps forward, but there's a long way to go. All right, I'm going to keep going. So another area that often needs some accommodation is scheduling. And most of these are actually prompted by the provider organizations. These are not necessarily things that the patient asks for, but the provider says, okay, I need you to schedule a double appointment time or a longer type of appointment. We normally have long appointments. Primary care might have longer appointments that they usually reserve for physicals, but they want certain patients to use them all the time. There might be specific appointment time windows so that they have key personnel available, or it's a time when they have more personnel available so that they can have more people at that patient's appointment without impacting everyone else's care, so that it's more likely that it will be successful. There are issues with that. We'll talk about that on the next slide. Booking a specific room or location so there's an accessible bed, a wider doorway, a special chair, etc. And again, having that additional personnel available to start to help, even having a second person to help someone who needs help getting from a prone position to upright can sometimes be an issue. So the next slide actually has an example. So this is an example. This is actually a true example. This is what someone I know is asked to do. For a patient getting a mammogram, may be asked to book a double appointment between 10 a.m. and 3 p.m. Monday to Thursday. And this itself is an equity issue because everyone else can book from 8 a.m. to 8 p.m. Monday through Saturday, or maybe the Saturday hours are lower, but there are evening hours and weekend hours that other patients can take advantage of when they're less likely to be working. But this particular patient has to do their mammograms in the middle of the workday on a weekday. And the extra time allows the pictures to be taken without the clinic falling too far behind. And it allows a second tech to assist with the process because they have fewer techs working in those evening and weekend hours. And Now, this particular patient also needs to take some muscle relaxants and painkillers to enable sufficient movement that they can actually get the pictures that are needed to physically accomplish the test. This set of medication is to be taken on a set schedule, and it provides 30 minutes of effectiveness. So that patient starts taking the medication before they arrive, and the patient has to be seen during that 30-minute window they're given, regardless of how far behind the clinic might be, or they won't be able to get the test at all. So that patient also is given the requirement of being loud and obnoxious in a polite way, but pushy, I guess, is the right word. Has to be pushy with the front desk staff, or if they're in a waiting area where they have some access to people being called in, perhaps with the staff that are calling people back, in a way that might be seen as inappropriate or obnoxious, in order to get seen in a way that's in alignment with their needs because of their disability. So in this particular case, the patient has to go, they might have to miss an entire workday or half of a workday on a Monday through Thursday, because if they go at 10 a.m., they might not be able to start working until 1. If they go at 2, they might have to stop working at noon, depending on how long it takes them to get there, etc. And they have to do all this extra stuff, and then when they get there, they have to be obnoxious in order to get what they need. So yeah, it's not a pleasant, as Denny was saying, there are issues. And this isn't particularly unusual from what I can tell for that patient. So that's sort of the brutal truth of where things are at least in some cases. So what do we do with this data? Who needs to know this data? How does it get shared? So there are lots of things that you might not have even thought about in this area. I mean, yes, this data should follow patients from provider to provider, from clinician's office to clinician's office. But a lot of the data might be collected during scheduling or pre-appointment, and that data, if you're going to ask for that at that point, should actually go into the clinical data and get shared from the scheduling system to the clinical data system, so the patient doesn't have to repeat it. If the patient has a conversation with a clinician or a tech about a procedure before having the procedure, and that data gets captured, it needs to be captured in a way that it stays with the appointment. And if the appointment gets canceled, rescheduled, moved, that information needs to stay with the new appointment. And that's something that happens a lot, where if they could, there are patients who've spent time, they've ironed out with a clinician exactly what needs to happen in order to have a particular exam. The office cancels the exam because they need to change the time. And when the new exam is scheduled, they have to start from scratch. So that's not good. There can be certain things that you have where you have a different staff helping out a patient before a procedure or a test and after. For instance, if you have a colonoscopy, there may be two different waiting areas, one for the prep area and one for the post procedure area, recovery area. And if the patient is sharing information about what they need during the recovery with the staff that they have access to, that information needs to be shared with the recovery staff. None of these processes exist in any significant or consistent way at the current time, as far as I've been able to determine, and they're all important for this process. And furthermore, there needs to be consent, there needs to be provenance, there needs to be support mechanisms around the data and the data sharing. So this is kind of a nascent area that's really important. It's something that we've pushed when we've had the opportunity. It's something, as you can probably tell, we've done a lot of thinking about. We've had a lot of conversations with different groups about, but it's really important. So what do we recommend? So making some of these policy adjustments, starting to try to figure out how to do some of this data collection and some of this interoperability. And we outline all of this in more detail and give more examples and specific types of things in those regulatory comments that are linked up front. But at a very minimum, a baseline requirement of always ask the patient what they need at every touch point. because at least if you don't have it, you give them the opportunity to repeat it. They might think you know about it, and at least at that point, something can possibly happen. It may be too late. It may not work, but there's a chance. So at least have the courtesy of asking about it at every touch point. And then here's that idea that we were talking about before: disability advocates that function like language interpreters, that they can be requested and scheduled in advance, and they can help patients fill out paperwork. They can facilitate communication. They can advocate for the patient, especially if the staff may not have had the opportunity. And as Denny mentioned, they can also work as sort of a group of systemic advocates for the needs of the disabled within the organization. So if you walk away with one thing, what I want you to walk away from this from is that you should think about disability and accessibility in all of your programs, your policies, and your workflows. Let's start working on it. We can do it. We can do it together, but you just need to get started. It doesn't all have to be done at once, but let's get started on it. And let's just make sure that it's a thought when we're doing with everything that we do. Any questions?
This was a great presentation, Janice. I don't need to speak for the group, but thank you for sharing this with us. I think it's opened our eyes a bit, and I appreciate your sharing your insights.
I agree with it.
Thank you.
This is Marilyn. I mean, I think that this was really excellent. And I hope it continues to get traction, because it is a group of patients that don't get what they need, you know, to be able to get the full set of health care. And so I think that there needs to be a lot more communication about this as a disparity. So.
Thank you. And I agree. And this is just the tip of the iceberg, and there's all kinds of other needs, other types of disabilities. This was not a systemic effort to figure out the needs of the disabled. This was conversations we had with people who chose to be at those conversations. And so it really is just the tip of the iceberg. All right. Well, I'm happy to answer any other questions or comments from people. If not, our next meeting, I believe, Ariana, when's our next meeting? Is it July 19th?
Let me verify 1 second.
July 19th is the next health equity work group meeting. And hope to see you there.
It's July 18th.
18th?
At noon. Yes, ma'am.
July 18th, I'm sorry.
Okay.
I even looked at it. I looked at my calendar and I still said the 19th. July 18th at noon. All right, well, thank you,
all.
everyone.